MBBS basically means you wanted to become a doctor in medical career. So that requires also a lot of passion because the study is going to be too long. The courses are very long. You have to do an MBBS, then you have to do some board specialization, then you have to do a super specialization. So you need to be very passionate about a career in medicine. So because it requires a lot of years, a lot of sacrifices in terms of personal leisures of life at young age, uh, because it requires a lot of hard work to become a doctor. It requires a lot of investment personally, not in terms of money alone, but in terms of your time, your effort, your attention, and the kind of studies we have to do in medicine. You cannot do unless you have a great amount of passion for the career in this. So for me, the reason was I always wanted to be. Honestly, I wanted to be an engineer till eighth or ninth standard, and suddenly after that, something changed in me. Around ninth, when I was finishing my ninth standard, I decided, no, there has to be something meaningful in life. You do something which not just affects you as a person. Your career should be useful to others. Maybe somewhere I went through that phase in where I was, my thought process was evolving. So in that situation, I thought, okay, I should be focusing on this. My parents were very happy to allow me to take this, and that's how, like, somewhere I felt, okay, this is something I'm passionate about. I gave it one full year because you choose the next subject after 10th standard. Mostly in plus two, you choose the subjects. So before that, you have to make a call. So for one full year, I was under this uh, decision making process, and I realized that this is what I should be doing in life. Uh, and there is a lot of scope, there's a lot of passion, excitement there. You make a lot of changes in people's life, you evolve newer things. So that's how I went for a career in medicine. Okay. So the best part of this journey is that it is so challenging that you don't get time to get bored. So you kind of keep on
Right.
studying, you keep on getting new challenges. On second year or second prof onwards, you start seeing patients in clinical postings. So you get more clinical rather than direct book reading that happens in first professional this thing, when you read anatomy, physiology, and biochemistry, which is a lot of reading, and practical is only on normal individuals. But second prof onwards, you start going into clinical this roster settings, postings, and all. You learn practical situations, you learn clinical
Right.
evaluation. That drives you a lot. And then as you grow, newer subjects keep coming in. So your journey is, at least that this MBBS thing I have to complete. Then you realize, okay,
Right.
MBBS is a general special thing. MBBS is just a graduation. You need to specialize in something. And now it's a, like earlier days, say 20, 30 years back, people would have just left at MBBS and proceeded on with practice. Now you can't do that. Now you have to have specialization. You have to have maybe super specialization also sometimes, because you also need to be an expert in something, so that you whatever you whenever a patient comes to you, you do your best. So that drives you into that passionate
Yeah.
branch post
Absolutely.
graduation, and that goes on and on. During my MBBS, we used to get exposed to a lot, every specialty. Our clinical rotation postings are in every specialty. So for me, see, no one decides one specialty. It's not easy, especially in India. Many times don't get to choose what you want every time. So the practical situation is you cone down on two or three specialties where you feel you can really feel good about, or during your postings when you are working with those patients, or during your internship when you are dealing with those patients, you feel that, okay, this is what attracts you. This is where you are good at. Okay, so somewhere down during my internship, In fact, we didn't had a lot of oncology exposure. We had cancer patients exposure during our postings with surgery, ENT, and all. But proper oncology exposure didn't happen because there is no special uh, roster for oncology postings. So in internship, I got exposed to oncology, and there I realized there's a lot to be done in this space. And the kind of impact I wanted to do in my career, through my career, I realized this is the place where I can really make an impact because as a we are all scientific people. We are scientists when we are practicing medicine, when we are learning. Why do we call as medical practice? No other profession you call it as a practice. Practice. You don't call like a chartered accountant does not say I'm a practicing chartered accountant. A lawyer does not say I'm a this thing because practice it makes us perfect. We don't know everything. Science is evolving. Medical science is evolving. We are learning each and every day. So that's why we call it practice. We improve every day. We improve with every patient. So that's where I realized, okay, in oncology there is a lot of space to bring that change, to bring that uh, paradigm shift in people's life because it has a very high mortality rate. It affects. It's the most challenging branch. So my interest honestly was also in surgery, but again I wanted to somewhere enter into oncology only. But then, as the destiny had it, I realized at the end of my internship, okay, you need to have something which also uses technology. I loved technology. So radiation oncology is the only branch of medicine where you get exposed to a lot of technological advances. You deal with computer-based systems. You deal with high-end machinery like linear accelerators and all. Now you do treatment plannings on highly complex systems. So that's what also attracted me. So that's how I chose to join radiation oncology as a specialty. So that's a good question. Radiation oncology is a highly specialized branch, not just in medically. So when you are training in oncology, you are exposed to all specialties of oncology. You first year goes into clinical things a lot. As you grow, you go into specialty things. So as a radiation oncologist, the day starts with my clinical evaluation of patients who are new patients coming to OPDs. You evaluate them completely. We do their treatment planning, investigations, workup, staging workup. We plan their treatment, not in just in terms of so radiation oncology is my specialty, but primary specialty for every oncologist is the oncology part, comprehensive oncology. So I treat a patient coming to my OPD as a cancer patient, where whatever treatment is required for the patient, be it surgery, be it chemotherapy, be it radiation, we plan it accordingly. So I see patients in the morning, in the wards, then I go to my OPD. Once the OPD gets over by, say, afternoon or say around 12:30, first part of OPD, I finish off by that time. Then the second part starts on the treatment planning because new patients have been who have been advised radiation. So we do the treatment planning protocols. So right from the first day of their treatment planning status, and then we do planning on computers. Then we do QA testing. A lot of technological exposure is there during that time. And post around 3 or 4 new patients are taken up for treatment, and we execute the plan every day. New patients are being treated, old patients, because radiation treatment typically may last from 1 day single sitting to up to 40 fractions, 40 sittings. So you keep on those longer tenure patients, you keep evaluating them every 2 3 days. How are they doing? What is their side effects? Managing them. Then we do keep doing rounds also, ward rounds. Admit patients are admitted. Sometimes you do palliative care along with your other colleagues in the hospital. So that's how a typical radiation oncologist's day passes by. And if you, we had DNB also in our institution, so part of it also went into teaching to the students who are specializing in radiation oncology. Yeah, it's a typical day job. Good part of this is that you don't get emergencies so often. Other than like I would have experienced emergencies one in a year or a max five in a year, full year, when nighttime patient comes. So we give radiation sometimes in emergency situations, like there is uncontrolled bleeding from a tumor. So sometimes emergency radiation is given very high dose to, that is called hemostatic radiation. So those situations we have to come in. Suppose there is a spinal cord involvement and impending paralysis due to tumor involvement. So we do emergency radiation so that the paralysis can recover immediately. So there are very less situations. Other than that, our admitted patients sometimes they become bad, so we have to go. But mainly the management happens from the hospital side.
All right,
So
sir.
our life
And
is typically cool in that sense.
correct.
In terms of like emergency hours and all. We work 6 days a week, but Saturdays are like kind of less load because we treat patients only 5 days a week. Six things Saturday, Sunday is given for normal tissue healing. So we don't treat patients, but we do OPD and also first half we go to the hospital. If I have some other papers reading or writing, or we have a seminar or something in the class on the Saturdays, that's how the Saturday passes off,
All
and
right,
Sundays
sir.
are cool. Like so, in radiation oncology, as the specialty suggests, as I noted, I told you, we need an equipment called a linear accelerator, or some places, old places still have cobalt units. So you need a machinery, and those machineries you cannot put in a clinic or something. Our whole work, everything what we do revolves around those radiotherapy machines. So those are present only in hospitals. Our practice is limited to hospital, morning till
Right.
evening. We don't have evening clinics. Some radiation oncologists practice chemotherapy also. For them, they have separate clinics. Nowadays, this specialty has become so complex that we don't practice chemotherapies and all. We have medical oncology colleagues who do that, and we our whole day goes off because now the this specialty has advanced so much, and we have so complex treatments involved that we our whole day passes off in these things only. So by 7 or 7:38 you get free and you're back home. You don't practice
Right.
again
Right.
legally. So we should think of a good life when we are entering into medicine only after say around 10 years in this. So you someone who is entering MBBS, they should consider that they would have a decent, not very great, but decent work-life balance by after 10 years. Because you are doing MBBS, then you are doing specialization, and if you are doing super specialization, that goes off into another 1 or 2 years, 12 years sometimes. So you don't get opportunity of that kind of work-life balance as a non-medical friends do get. But now
Right.
after that, you get a decent this thing. Like any practice, any specialty, medicine is has also has its own issues. So it there are always challenges. Practice is a challenge. Working in hospitals has its own issues. But that's how life is. Anywhere you go, there would always be some challenges. But this is most gratifying or satisfying profession someone can have. Such cases, there are hundreds of them. So, like every now and then we experience challenges. Every now and then we have lessons for our lives also. We learn a lot from our patients. So, if I have to point out a couple of them, during my specialization, there was a patient, female lady patient. We had treated her, and she came back after 2 years. She was fine. Otherwise, she had some fever and it was not going off since 1 week. We admitted her for workup and all, and suddenly she started deteriorating. We found that she had a recurrence and that got infected. But then she developed kidney issues. I was studying in a government institution where the equipment and the infrastructure is not as great developed for such situations. But the kind in that situations, we all like I called my specialty colleague, other specialty colleagues from medicine, from nephrology, from surgery, my ENT colleagues, and we worked on that patient, and like she recovered. It was like we had told the family that she might not recover, but we could take care of her. We balanced her. So that collaborative thing. That's when I realized that when we come together, we should never think as a doctor that I am going to treat the patient. No, it's always a team effort. So that patient recovered only due to all of us sitting together, working on that case. At 1 o'clock, 2 o'clock, we used to get time to talk about that case. We'd call each other when we were on duties, and we would sit together, open her case file, ensure we read a lot during that period, papers and all. So that was the motivation. And that collaborative work resulted in a lot of learnings for us. And plus, the patient survived. She did very well. So that was one case where I learned that it's always a team. It's never you alone. Second came one very good case as a radiation oncologist. I feel that was something really achieving. Was there was a young girl? We had a patient from Kenya. She was just 13 years old girl. She had a tumor in her spinal cord, inside the spinal cord, in the center of the spinal cord. That tumor was compressing her spinal cord and causing her to have a paralysis of her limbs. The young girl used to run around like anything, was bedridden since 3 months. When we evaluated her, surgeon said, I can't enter, I have to cut through the spinal cord to reach the tumor. So that is not possible. So then we did a discussion. I was called in. I saw this thing. So there was we call it intramedullary tumor. That was intramedullary angioblastoma. So inside the cord, surgeon cannot enter. Tumor is paralyzing her young girl. So we decided to do radiation. Radiation also in that highly specialized stereotactic radiosurgery technique, where you do very high doses. Radiosurgery we call it because we give very high surgical or ablative doses of radiation. So we planned her treatment. We ensured that her spine was fixed, and then we treated her with the very high doses of radiation to ensure that radiation passes through the healthy cord, hits the tumor, and then we and should ensure that it's safe, because any high dose of radiation hitting the spinal cord would paralyze her forever. So this was a big risk we were taking. We spoke with the family. We spoke with the child. She was very clear that she wanted to walk, and we went step by step. We did some innovation. We went through a lot of literature, and that was one of the 20 cases reported in the world till now. And we
Oh,
could successfully treat her. It's been 3 years now, and she's running around doing. Her family keeps sending me her pics. She participates in sports and all. So
great,
that's
sir.
that kind of experiences make you have a great sleep every day. Yeah, so that's a challenge, but good part is that rigorous training that you undergo. During your residency, we used to be on duty for 36 hours, and then you get a 6 hours gap, and again I have to be back. So like we would be relieved at night, and then next early morning you have to be first to take the rounds before the consultants come in, before then assistant professor would come, then associate professor and professor would come. So that kind of rigorous training is there. That kind of rigorous repetition of things is there. So you kind of become very smooth on risk taking. You learn these things. Okay, I have to take this decision. Otherwise, I can't lose time. So you read so much, you learn so much from your patients during treating them. So we should always take our training part very seriously. Our clinical postings are the most important part of uh, training that we do, because learning from book can happen, but the real time practical training from your patient makes you remember that. So that's how you keep, because you develop it as a habit. You do so much work Residency, why they call it resident, because you're residing in hospital wards. You stay there, you're supposed to stay there. That's why they're called residents. So that's how it's world over. It's not just anywhere. If it is not a good residency, it's not a great place to study, actually. There has to be a lot of clinical work. The hospital has, that's why government hospitals, they say, are the best ones to really study, because you get a lot of clinical material. Nowadays, there are a lot of hospitals, even private medical colleges are doing well in terms of getting patients. So that way, wherever there is a lot of clinical material, wherever there are people teaching you, is important. And one part I want to emphasize on that we don't get to learn as a part of curriculum is the communication skills. That is why you would be seeing a lot of violence, or doctors many times face violence because they're not uh, taught to handle stress coming from patients. We are taught to learn or taught to kind of handle that stress that comes from the treatments, because there you are alone, you're deciding the treatment and you're more managing it. But when you do deal with patients who are, see, they are distressed, they are under a lot of stress, so they sometimes behave differently. They need some information. We need to learn to talk to them. That's the toughest part because you're not taught it. So you should practice it. Talking to patients, talking to attendants, family members, explaining them what's going on. You should know. You would learn over time what to talk, what not to talk. Sometimes we end up saying something which is going to, because people hold on to those words. So always keep them informed, but learn what to say, what not to say. So all this comes as a balance in life, in your career. So all this training is a must. So work hard, like spend time in wards, spend time in the hospital. That's where you learn the trick. And also don't forget to read a lot about your books, especially because those books tell you what to do in practice. So it's a full-time study. It's not something where you can enjoy a lot. You have to study, you have to focus on this thing. And what we can say that I can promise you that, okay, you spend that much life, but you develop a habit of enjoying the successes for life and enduring your failures for life. So, oncology is the most evolving branch. Every day you get new research. Every day you get more knowledge, more information about what new has come to treat cancer, because that's the biggest challenge humanity is experiencing in terms of disease. So, it is a very highly evolving branch. Now the technology has come in India, especially now, the technology is getting adopted. Lot of hospitals can have come up with such advanced machinery. You have a good life in terms of the practice and the work-life balance also. Plus, you do well in clinically also. You do good work. You do super specialized work. In radiation oncology, as of now, you need to do mainly MBBS and then you do MD in radiation oncology, and you then do go for a advanced some form of fellowship or some residency, senior residency or something that helps you grow. Then you should always go for international training, because that helps you become get an identity in a particular type of treatment. So that is important. So this is evolving branch. In addition to that, beyond radiation oncology, in medical oncology we can enter as in the DM course. So after MD in radiation oncology, you also get a chance to enter into DM in medical oncology. Medical oncology is also a highly evolving branch. Not many medical oncologists around, so it's not saturated. Radiation oncology, still there are a lot of people, but it requires some time to settle in career. Medical oncology, if you go for another 3 years, of course, you kind of instantly get settled. Then you practice only medical oncology. But so this is a choice you can make while you are studying in radiation oncology, that you want to enter into domain of medical oncology. So you can do advanced treatments like chemotherapy, immunotherapies, and targeted therapies. All that newer treatments have come. But again, it's another 3 years, and again, it requires a lot of endurance and hard work of that level to do another super specialization. But this is a most exciting phase to be in oncology, and this is going to stay for next 20 years or 30 years till the time we get something which is routinely makes us cure cancers. So it depends on country where you are. I don't know much about where, especially there's a huge gap or opportunity to do good work in oncology wherever you go, in India or anywhere you go. Even in US, people who go for USMLE and do, we are there. It's a longer process. After MBBS, you have to start planning for internal medicine residency and followed by fellowship in medical oncology, or you get a general surgery residency and then fellowship in surgical oncology, or you get a again an internal medicine followed by a radiation oncology specialty. So in US it works like that. In UK and Europe you have to specialize in and do a FRCR, fellowship in Royal College of Radiologists. FRCR is both for radiology and radiation oncology. So we have to select one specialty and give the exam accordingly. If you get an FRCR cleared after training, of course, after MBBS, you have to undergo 3 or 4 years of training in radiation oncology. So if you clear that exam, you are entitled to get a job in UK or European countries accept a lot of it. Gulf countries, especially Dubai and all, they accept the FRCR certificates from UK, so you can get a job anywhere. Then in India, of course, radiation oncology is there, or medical or surgical, whatever you want to do. It's immense possibilities, both more than radiation oncology. Why? Because there are a lot of more, radiation oncology was the first specialty in oncology that started in the country. Later came the training in surgical and medical oncology. So we don't have so many of medical and surgical oncologists, but there are a lot of radiation oncologists. So the careers take time to pick up nowadays. For my time, it was almost 12 years back, 13 years back. It was not that tough. But for any specialty, it becomes as the time passes because you are dependent on a machine. So you have to spend more time. It's not like career does not grow. You grow in career, but it takes a bit of more time, and you need to get more and more trainings. So there is, and if you go to other countries other than these I mentioned, not much knowledge I have, but oncology as such is in high demand across the globe. What specialty you want to do again depends on what you like to do. Oncology might be depressing for some people because it's a challenging specialty. Cancer is a difficult disease to treat. There are so many factors on which your treatment results depend. So we don't know exactly what works for you, what you like to do. And if you're really passionate about research, also, if you want to grow in further research in, or do advanced therapies or more technological exposure, then radiation oncology is a great specialty for you. There's a lot of scope, there's a lot of technological exposure that you get. For you, me, as you mentioned earlier, I have now entered into pure technology space by I am a co-founder of a company called Onco.com, where we are building an online portal to help cancer patients get information about their disease, information about their best treatment options uh, based on international protocols. So we are building technological protocol softwares for patients, even for doctors, because there is a lot of information coming into the system. Every doctor can't read. So we are working on clinical scenarios where we can do some automation and get some information about the new disease processes, the treatment protocols that are coming in. So there is a lot of scope. Even after you do, there is a lateral entry option into so many other careers along with your clinical practice. But most of the people who come into this are for clinical. Even I love to do my clinical practice along with being founding this company, because that's what drives you as a doctor. But some people, a lot of people now are entering into management, into there are bigger pharma companies, technology companies, where you can enter as a specialist and have a easier life and a good doing something for the future, working on the kind of research that you're doing. See, everything is important when you are becoming a doctor. Okay, everyone should be a very good doctor. So to be a good doctor, you have to excel in all subjects. Medicine requires you to remember what you learned on first day of your MBBS course. In till I need to remember what I was taught in first day of course during my practice today also, because that's how things work. You need to know everything, and you need to have a good hand on everything. But if you say you want to uh, there are different ways in which you should focus on subjects. In general, we should focus on all subjects because everything affects our practice, our knowledge, everything what we learn during MBBS or later comes in front of us at some time or the other. So we can't really say, it's not possible for me to really say, how would I tell you that anatomy is important to know everything you need to know. You need to be very good at basic sciences. First year is the most important year, in fact. In pharmacology, even if you forget some things later, you would learn in medicine when you study medicine. But anatomy, physiology are two baseline subjects. Similarly, biochemistry is very important. So all basic sciences are very important. You need to have a good hold, great hold on these. And if you want to
Absolutely.
go into surgical or radiology or radiation, wherever, anatomy is an important subject. So I would love to have something coming from Ayurveda which help our cancer patients. See, as a doctor, we have to be very neutral and open to that anything that can help us treat patients. We are not biased for or against. Since we study an allopathic system of medicine, we know it more. Ayurveda, but only process. See, as I mentioned earlier, we are scientific people. We are not following anyone. We are following science. So if something comes out which proves by scientific protocols and processes that this works for cancer, we should use it. We can use it. But unfortunately, those protocols, those scientific processes have to be followed first. It has to be proven beyond doubt that something works. See, it's a big responsibility to be a doctor for someone and treat a life threatening condition like cancer. You need to be very sure about what you're suggesting. And you how you can be sure? Not by your own experiences. Has to be a data, research, protocol, clinical trial or something data that supports what you are suggesting. You're handling a life. You need to take this into account. So whatever you suggest as a doctor is a big responsibility on your shoulders. And you can't take it lightly. So it has to be best, whatever you suggest. If Ayurveda comes out, why not? We can start referring to our Ayurveda doctor colleagues. But we need to have enough data that it works. It's on you again. You have to be passionate. Whatever you are passionate about, you would do it without any regrets, whatever it takes. Okay, so you make choices. Your heart makes you make choices. Then you don't go for, you don't call it sacrifices. Like, I don't call it a sacrifice. Maybe I kind of left those leisures of my life for my passion to be in medicine. So it requires again a passion to do something. Okay, so you love it, you want to do it, then it's not a sacrifice. If you are made to do it, if you're forced to do it, then you're making a sacrifice. So you have to enjoy what you're doing. Definitely, but even if you are going to medicine, I would suggest take out some time to enjoy, because that young age you need to have some things where you really have some time for yourself. Maybe on weekend, take 2 hours or something. Maybe our time it was much more tough. We didn't had so much of technology when we were studying medicine, like internet and all based learnings. So now you have a lot of other ways of learning. So you can save a lot of time reading books and all. You should spend time going on weekends or fortnightly out. Spend time, and then you won't miss it. But yeah, you won't be doing as great in terms of enjoying life to present day as your non-medical colleagues. You would realize
That's
whether it's worth it or not when you are in practice. Then you realize कि, okay, whatever grade you are achieving for each and every patient is worth is coming from that sacrifice. So that's how it's worth it. So it's important and it takes time. You can't. We are all human beings. Emotional attachment is part of what we do. Okay, we get attached to our friends, girlfriends, boyfriends. So these are our patients whom we are helping come out of bad times. So we get attached. They we lose them. We fail sometimes. We are all humans, so we should not be very. But we you realize over time that that's how it has to happen. You do your job, you do best in terms of your job. Attachment or emotional thing would happen, but still you need to know how to get unemotional about those things. Because see, this would happen. Don't stop it, but you have to learn to move on because you can't stop because there are other patients who are coming for you. That's how you move. But emotional, we like we treat patients over months or years, and then we lose them sometimes. Many patients are recovering also nowadays, cancer patients. So we lose them, but sometimes. So we feel bad. I would have cried sometimes during my early years when I was alone. What is happening in this career? People are dying right and left. So that happens, but then you have to move on. That's where you learn. Okay, with this patient, this kind of things happened, and then you need to move on, learn, and then move on because your job is to keep moving and helping more and more people who come to you. That's how a doctor's life has to be. Emotional part would don't stop it because it would come, and you would over time learn to get detached also because you're into so much of it that you become thick-skinned somewhere. It doesn't affect you in that sense. You should never become weak for those things because if you become weak, you are going to fail further. So that's how I keep myself. I don't take credit of what good I have done. I don't take blame of what has happened. That's how you have to detach yourself. Because if you blame yourself, then you live in guilt. And if you take credit, someday you would fail also. So better is to stay away from the credit and the blame game. Yeah. So there are mechanisms, there are ways, there are protocols to ensure that machines are working properly. There are QA protocols, quality assurance we call it. So every day there is some QA test that happens to ensure that machine is functioning properly. Every week, every fortnight, every month, every 3 months, there are different protocols to check every machine that it is accurate, it is treating well, because there are so many machines involved nowadays. So you do a QA test. Under ideal situations, does the machine perform? Like in radiation, we keep measuring whether the machine is delivering the desired radiation dose. There are different QA protocols that we follow, and we ensure that the machine is functioning well. So that is not a and machine malfunction would always happen. That's how we are there to handle situations, and there are engineers to take care of it. Radiation machines do break down, and they are repaired and they start functioning again. So that is all part of this thing. You can't control those things, and those things are bound to happen. So and
right.
even ventilation machines fail. So there are ways to handle situations. US and UK requires a clarity of thought that you are ready to go to USA, whatever it takes. UK is not a great destination nowadays. They say because
Exactly.
it's becoming tough. It's becoming tough, they say. USA has its own protocol. They have that USMLE exam and all after MBBS. So you have to be very clear that you it takes time. You have to give those 2 3 stages, whatever it was. I never wanted to go to USA, so I never inquired much about it because I love helping patients and I make decent money here also. So why should I think of USA? If you want to have a US life, then you need to think of places like USA. Otherwise, you serve here and you make decent money here also. So India, it's easier to get a seat. or it's not so easy also because of the exams that you have to give PG entrance. In US also it has its own issues. So it is tough everywhere. But that's how
So,
the day starts when you say you want to become a doctor. That's tough. So I won't say easy or difficult. What I liked, I would tell. Maybe they were easy also. So I
mhm,
loved anatomy. So I loved anatomy. I would always, well, I always think about what's in the human body. I was very active in dissecting dissections and all when we were doing the cadaver dissections you do to learn anatomy. So I loved it. Physiology was I was good, but I was in love with anatomy, if I can say, and I was great at that. I want lot of impromptu prizes from my professors. They would ask random questions which were like out of blue, and I would like I loved it. So that was one. Then I loved community medicine. Ironically, many people don't love it. I did it. I liked it because somewhere I felt that's where the mass scale level impact can happen for a lot of people. Then I loved surgery. I always used to do good in surgery. Uh, Oncology was never a subject as such during MBBS, other than internship. But I was good at those. And pediatrics I liked to decently. Other than that, like other subjects were I pharmacology and all. I was other subjects I was good at otherwise, but I loved these three four subjects. So Netherlands, I went for a high-end treatment protocol, SBRT they call it, stereotactic body radiotherapy. So that's a radiation oncology related high-end fellowship training was there, short training, where that's the most advanced technology for tumors in liver, lungs, prostate, where you give very high doses. We call it like ablative doses, surgical doses of radiation, highly uh, sub-millimeter accuracy of radiation is given in that with moving organs also moving tumors like liver and lung they when you breathe they move up and down so with moving tumors they can do live tracking and live radiation treatment can go on so that was the beautiful part of that training that you do 4D you would have heard 4D movies but we have 4D CTs also where you see live moving organs while the CT is being performed. So you kind of learn to track those tumors and treat them while they are being moving also. So while moving, there's a concept called gating and all. So all that you learn. So that was the most exciting part of it. Again, technology plays a big role. Then they have used MRI machines for along with radiation treatments that had never happened. That was first machine in the world. That's why I went to Netherlands, and it was an amazing experience. You learn a great from visiting abroad. So always ensure in investing yourself in training yourself by going abroad or going for these things. Conferences sometimes don't help, but such visits, such small, short observerships or fellowships do help. See, all patients are important. As a doctor, every patient should trust you. If they're not trusting you, you're not talking to them enough. You're not explaining them things enough. So you might be great at your subject or your procedure or your surgery or whatever you do. But if your patient is not comfortable or the family is not comfortable, that means you have not spoken to them enough. You're not explained to them enough. So they should be trusting. Everyone should be trusting you coming to what you feel, we feel under pressure when we are treating our known to us or relative or someone. So that pressure automatically happens. Being human, everyone feels that pressure. Everyone feels that okay, they're your loved ones. So even if you are not emotionally attached to your patient, sometimes, but you that profoundly comes from inside. But eventually, since you have done a lot of work in this we what I used to do, I would like just do it as I should be doing it, like a textbook procedure or treatment, whatever I have to do. Because see, that emotion cannot come in my work that I do. If emotion works on me, then it's not good. I'm not a great doctor, because as an emotional individual, my emotion should be limited to the fact that I devote my best for every patient. Beyond that, emotion should not affect me, be it a success, be it a failure. So you just do your job. And what I used to do sometimes initially, when I was not as developed, you mature over time. Very early stages, I would call my colleagues, involve them in the decision making process, discuss with them the case. That helps you. So again, collaboration, teamwork, that gives you confidence, and you just go on. But you should always talk to your patients very well, explain them everything, go to their level of understanding and explain them. It always helps. So these things you learn from the faculty you work with. So when your professors and all, they are involved in the research, you should have that interest in research. Journal means you're publishing things which you want to tell others, that this is something new I want to tell, or this is our experience, that we have worked with these situations and with such type of cases. Be it a single case report, which is a rare situation, or you do certain level of research, an intervention basic, or an observational study. You need to have that approach towards things. So one of the professors I had used to say, it's a crime to not to publish your work, because we should share with our colleagues what work we have done and how patients did. Not just research means doing a clinical trial. Research is also observational study. Like when we I did some things, I want my whole idea was that I share what I am doing and my observations with the fraternity, so that when they are treating patients, this is what to expect that might happen. So it's not limited to only doing some clinical trials. Research means, or publication means, you're sharing your experiences in a scientific manner. So you need to learn what is the scientific language that is expected of you. You should know, you should read a lot of papers. Once you read a lot of papers, you get to know, okay, how, what are the things that they write in the papers. That's why they were selected. So in general, what gets published in journals is which is well written. One thing. Second is which is new, or something which gives a new insight, or maybe adds to the available information, but in a new way. Okay, newer technology that you have worked with. Suppose you have worked in a new surgical technique for that, and you start working on that, or you do a study like this drug. Like suppose you have 10 drug options for a particular disease, and you have given same one drug to 100 patients and another drug to 100 patients over your practice. You note down all that data, and at the end, you noted that drug A is better than drug B for a typical set of patients. And you share that information. Okay, for such type of patient, drug A works better than drug B. So others knew that there are all the drugs are same, but you told them that drug A is better than drug B. So you don't do a trial, but you, from your observations, you noted all that data and then published it. You should read a lot, but papers reading is a good habit.
Hence, yeah.
So we are all humans. We do fail. We do procedures. We do fail. We do treatment. Honestly, all of us commit mistakes, because so none of us is perfect. Even dog is not. Sorry, even God is not perfect. That's why never comes in front of us. So we are all humans. So we do fail. We do mistakes, but that's where we learn, and that's where we. That's why you would find a lot of papers where they would tell you that they were doing something consistently and they found that that was wrong, and that's why patients were having complications, so they changed it. So it's not that they failure, that failure they shared so that others don't fail. So we talk about it, we talk a lot among ourselves. If you enter in medical school, one strange habit you would develop, that you would talk very well with your colleagues, with your medical colleagues, but you would become very kind of introvert when you're talking to non-medical colleagues, because you develop it. That's your stress reliever. When you talk to your colleagues, you tell them this is what happened, this is where you failed or you screwed up things or something happened or patient was bad. So every patient comes with their own case, with their own destiny. That's what it has to happen. So we should always focus that we don't leave anything or we don't commit any mistake, but that can happen. Just go and talk. We used to go and talk to our, sit with our friends and have a cup of tea or coffee. So, or some, we would just talk about it and learn from it and just move on because we can't change things. So that's why, as I said, no credit, no blame. So, message is, see, it's a tough career. Okay, it is going to take a lot from your life in when you are studying, when you are learning few things, when you're doing many things. So it would take a lot of your life. Okay, so be very diligent, be very focused on your thing, be keep yourself cheered up, always talk to your friends, never ever go away from your friends. Keep talking to them a lot. Okay, and that's how you learn. So
Absolutely.
and keep learning and be always happy with what you are doing, be proud of what you are doing, otherwise this is going to lead to depression. So be proud of what you are doing, never compare yourself with others, especially non-medical people, otherwise it's again depressing that they are enjoying some time and you are slogging in studies or in your wards in PG or whatever. You just be proud of what you're doing because you are going to have a career which would be lifelong. You never retire. A doctor never retires.